Uh, Good evening, everybody. I'd like to welcome you all to either the live event we're having this evening or to the recording. The recording will be made available in the next few days. I want to introduce you to a good friend of mine, Rachel. We've known each other for, well, I suppose it's over a decade now, but I don't know how that is because we're both still in our 20s. But I'd like to introduce Rachel to just give us a little bit of background into how biomechanics education came about, the people who were behind it, and how it's developed over the sort of last decade. So, hi Rachel, could you tell us a little bit about yourself, please?
Yeah, thanks for inviting me on. And yeah, it's definitely, I think it's might be 15 years. It's around that. And actually, it was when biomechanics education was in a previous under a previous name. So to go right back to 2006 was when Martin Haynes and I began to develop. Well, he approached me actually and said, I've done some research, which was quite interesting. So he's a background in chartered physiotherapy. He's a remedial gymnast, and he had 20 odd years of collecting data on about 4,500 subjects. And he did that in a facility he had down in London using ice kinetic machines and the manual tests he knew as a clinician. And he'd done this study, which I'll talk about again in a moment. But it was so interesting, the results he was getting, that he wanted to develop it into education. And so I joined him, Ross Shuttleworth, a physio, Nigel Morgan, sports therapist, started the process. And we didn't do it very well in the beginning because we were doing what is now an 8-month diploma. We were trying to deliver the first portion of that in about 3 days. And we started with sports coaches, but we found that their level of knowledge in anatomy meant it didn't really sit right for that the level we were giving it to. So we pivoted into the exercise sector, and personal trainers were sort of clamoring at it. So to give you the sort of the context of it, originally we were Mobilist Healthcare, Mobilist Performance part of the healthcare group. That was, I think, 2000 until 2009. And then 2009, 2013, we became Intelligent Training Systems. And at that point, that's when Mike Bryce came on board, Anthony Fletcher, and we became directors and developed the course even further. But the original sort of study was born from Martin, as a physio, was working with, he had all this ice kinetic machine, I think about £250,000 worth of ice kinetics. And so back in the 80s when that was, every other physio was bringing their clients to him as well as his gym goers. What he was finding was that with the standard physiotherapy model, he was, and I'm being very simplistic here because it's a short chat. He was finding that to assess and treat the area that was uncomfortable, painful, symptomatic, while initially the treatment worked, they went away and felt better, they inevitably, many of them came back with the same problem recurring. So we recognized there was an issue with the model of practice that he was using. So he literally, through fascination, started to assess them while they were fit and well. So his client base was Daley Thompson, Linford Christie. So many of you maybe don't know any of those names, maybe just me, Gary, I'm not sure. As well as kind of Barry and Sue down the local gym, his nan, his mum, you know, were going through the assessment protocol of clinical tests while they were fit to understand whether there was a movement limitation that, as he followed their medical history, resulted in those symptoms. And so he started to piece together the diagnostics that he was using in clinical practice pre-injury, so just as functional movement screens, alongside the ice kinetic machines. And some of the screens were coming out as 97% gold standard lab test accurate against Zevi De Beer's work in pelvic function using ice kinetics, just using a manual screen on a massage table. So that's the basics of it. But I think the nuts and bolts of what I think a lot of the people watching this might be thinking about is how is that different to what we already know? So some of the tests obviously will be familiar, but what we did and what Martin did and what we then developed was a system of approach, because simply going to the symptoms wasn't always working, and more often than not doesn't work. I mean, you hear about don't chase the pain, you know, the idea that if you just follow the symptom, it doesn't always solve the problem. We all talk about the body being integrated. We know that, everybody talks about it, but there's not many programs that actually literally assess everything irrelevant of what a client comes for. So this program is about a full assessment of every joint, structure and system within the body, as near as damn it as you can, without any need for expensive equipment. So there's the pelvis, spine, shoulders, knees, feet, the myofascial, skeletal and neural subsystems that are tested in isolation. And we take into account in each isolated test the entire body. So it took time for us to develop it, but over the years, and certainly with Mike Rice's input, Fletcher's input, and the evolution of the course, the system's robust in that if it's not an injury through trauma, i.e. car accident, fell off a bike, those types of injuries, it's more of an insidious lifestyle modern ailment, this works wonderfully. And so the beauty of it is, because we teach to move away from the symptoms, because predominantly a lot of our audience are exercise professionals, it becomes very safe, but it can still work. But a part of the process is to connect the clinical and the exercise world together, or the medical and exercise, or therapeutic and exercise. So it's the system that developed and became the sort of the intellectual property, it became the real gold dust. And the system applies to both the assessment process, but also then the application of the interventions. So using muscle energy techniques, nerve mobilizations, pure joint mobilizations, combined with antagonist and agonist strength work to take advantage of reciprocal inhibition. So everything is following a system, and what that does is it removes the guesswork, because you're following the system, coupled with everybody's individual expertise, whether you're a clinician, a sports therapist, a podiatrist, personal trainer. Because you're following the system, it allows you to rule things out as you work through the body. And one of the key things we see, for example, is if you have a client with a sore shoulder, generally, I'm being generalistic here, we assess and treat the upper body area, joints above and below. But we can show how, actually, if it's not getting better, quite often it's the pelvis on the opposite side, it could be right down to that foot. So unless we're assessing everything, we might miss the thing that is actually the root cause. So we fit into a lot of audiences, and where it's the program has been developed by so many different professionals, it's got a nugget from everybody. Exercise professional, Mike's obviously background in personal training, osteopathy, the strength and conditioning there, and then obviously Martin's background as a physio. So it's taken several forms, but Biomechanics education started in 2013 when we separated everything out, because we were doing everything, software, product design. And so Mike went off, did the therapy side. Martin has a company called Bright Spark, so he does product design and development of innovation and software. And then I took the exercise, the education piece, but we're still inextricably linked, so to speak.
Okay, when you were talking there, you mentioned Daley Thompson. I do remember him, and coincidentally watched a very good documentary about him last evening, about his quest to be the first person to ever repeat his gold medal. He did it twice. He competed. He held on to the gold medal. Then he went to Seoul in '84, I believe, and he described himself as being at his peak. And he was in a practice jump on the pole vault, and when he landed on the mat, he felt something that wasn't quite right, and he'd got an adductor strain. And if I'm right in my thinking here, some of the skills that you talk about were the skills that were employed by the physio team at the time to get him to be able to compete throughout the competition. And he was 22 points away from a bronze medal, even carrying an injury. And if you look at the images of him, on the 1500, run, heavily strapped up, you can see an inch worth of bandages on his thigh. But yeah, it was remarkable that he actually competed. I made some notes here again. When you're talking about the correlation between the shoulder pain and the opposite hip, this may the pelvic area. This may be again touching on the work of people like Tom Myers and his anatomy trains that some of you may have studied. So I think it's particularly useful because if we go back to our 10 or 15-year period that we've been in education, what I'm finding is that the course that I did in the early noughties, which didn't have a numerical level attributed to it, was really, really comprehensive. And there was a lot of objective testing. There was a lot of what we then call special tests, which we now call not very special tests. But there was a lot of emphasis on movement screens and joint assessments, muscle strength assessments, etc. And what's happened over the past decade, particularly in 2009 and 2014, in the sports massage, it's become a much more watered down package. So the skills that you're talking about are the skills that have been lost. And now the level 3, as we spoke earlier before we went live, the level 3 course has now become, since March, it's moved to the fitness industry and become known as massage for sport or massage for performance. And that's really great for those PTs who just want to, who with respect have more limited knowledge of anatomy and physiology, probably better on the exercise, but not as much on the soft tissue skills. And it might be really appropriate for those to use those, those massage skills just as an adjunct to their PT sessions, much the same way as the soft tissue therapists use exercise as an adjunct to their soft tissue work. So I think that this does fill a gap. I think that in education at the moment, even if we look at the degree programs, there's no continuity of standard across the board. And I mentioned that geographical location and the course lead may have an influence on the bias of the course. And I mentioned earlier that one university is heavily weighted towards strength and conditioning, one's heavily weighted towards pitch side trauma, one's heavily weighted towards manual therapy. So, we can't safely say that this is not appropriate education or CPD for an academically trained sports therapist, because we don't know the skill set that they come out with. Even though they've all got the degree, which has probably the same name, we can't safely say that this is safe for them to use, or good for those to use, and not good for another demographic to use. So, in your opinion, how is it useful for a PT versus how is it useful for soft tissue therapists versus how is it useful for somebody with a more comprehensive exercise knowledge?
Yeah, it's a great question, and what's difficult is when you're trying to explain something without people seeing it or experiencing it, and learning the system as is. So personal trainers are not given any MSK skills. It's not their fault. They're the level they are. It's that system, and we satisfy that group really, really well, giving them the assessment process so they can be more bespoke with their exercise programming. Same with the level 3 sports massage therapists, gives them a more thorough understanding of anatomy, movement, and then in application, an extra skill set. And again, we talk on the courses about insurance scope, what they're able to do, what they're not able to do. And a big audience we have are those two groups combined, along with level 4 and level 5 sports therapists, Pilates teachers as well quite often. And so within the courses, what we're doing, as I mentioned earlier before we came on live, we would teach the same content, but there are assessment processes, there are exercise processes, they all fit into a system. Sports therapists are usually quite interested in the exercise portion. Parts of those exercises they can deliver, parts they may need to look at their insurance scope in terms of writing a strength program. But this is where the personal trainer could become an ally. So for the sports massage therapists at level 4 and 5, there's still the system approach. So to go back to the question of what's it relevant to each group for, how would they apply it? they'd all apply it differently. And it depends on the individual's goal. I think what you say, Gary, about different levels of education, you've got to combine with that different levels of confidence and comprehension. Even with the same course, different individuals can have a different experience and different interpretation. So some individuals may be really quite confident at level 5, and as you say, experienced. Others may be less experienced, less confident. They're not quite comprehending yet. They want more development in certain areas, and they might have experienced a different type of level 4, which is combined with that. So what we give to each demographic is a system that connects us all. It's more commonly compared to assessment processes that level 5 sports therapists would use. I guess the difference we give is a system to follow, and then a common skill set to a personal trainer if they wanted to work within a team, and you had personal trainers and Pilates teachers who had the biomechanics coaching skills. But it's a very individual thing. Some level 5s won't want it, won't need it. And in terms of the big course, it might be an expensive CPD for that group. A personal trainer will invest that money. They see the value of getting more clients, getting better results, feeling more confident. And so I think it is about the goal for the individual as well. Because I mentioned earlier, we've had surgeons, we've had nurses on the course. We recently had an orthotist last year who was obviously his focus was feet. So podiatrists really enjoy it because they learn about everything above the pelvis, and how the shoulder can actually influence foot function and take pressure off foot problems. So for that demographic, it's really helpful. So I think the system is the different aspect to all groups, but the skill set might look and feel very similar to what a level 5, maybe 4 sports therapist learns.
Just for clarity then, for those people who may be watching this after we finish and watching the recording, if we look at we've spoken a lot about levels 3, 4 and 5. If I just take a moment to explain the difference between those levels. Now, I come from an assessment and education background, so if I'm assessing a student, a candidate at level 3, I'm purely looking at how they apply the skill. It's an application-based course. So the personal trainer that you mentioned, I would be assessing their ability to deliver and apply their knowledge and understanding, which is levels 1 and 2, a training session. Okay. The level 3 PT will apply these analytical objective tests, which then sets them into the level 4 scope of practice, which is wholly analytical. So if I'm assessing a candidate at level 4, I've already assessed their application at level 3. I'm assessing how they get their subjective and their objective data from which to clinically reason a treatment or a training direction. If we then move on to level 5, that's all about synthesis skills. It's about putting together those rehab programs, those periodization programs. So if I'm assessing them, it's more of an interview rather than a classroom-based assessment. So that's the differentials between the levels 3, 4, and 5. If we then go on to level 6, which is the degree, degree standard, and there are no level 6 qualifications that are not degrees, despite what you may see and hear in the social media. Those skills it's all about sort of critical reflection, if I can say that. It's about having a look at what you've done at level 3, the application of your skill, the analytical behaviors and the analytical tests, and how you've put together all of the programming, and then critically evaluating whether or not you've done your best for the client. And what was really interesting what you said earlier was that PTs will invest, right? And what I like that, because PTs are investing in an outcome. What we do in our industry, we tend to list services, and people don't buy services, but I always say they invest in outcomes. So if you've got an additional skill set where you can more comprehensively collect analytical data from which to clinically reason, it's highly likely that if you're competent at your job, you're going to get a better outcome. And so it's that investment that the client's making in your experience and your knowledge and these extra skills that you may have to make you the better therapist, to make you stand out, to make you to be different from Joe Bloggs down the road.
Yeah, and we part of the training is critical analysis. So at the end of the course, there's a practical assessment, of course, and then the sort of theory side is you collect the data on the assessments, and then you take clients, you produce evidence of the screening results, and then your decision making. So we do stretch level threes quite a bit, and so that's where I guess there's that crossover into what you describe about critical thinking and analysis, the self-reflections, have I done the right thing? You know, was there another option that I could have used? Did I use the Occam's razor theory of, you know, the simplest solution first? So we do take them there, but you can see the difference in the work between level 3, 4, and 5. But it works quite well having them all in the room. And as I said to you earlier, I quite enjoy having all these different practitioners in the classroom sharing their thoughts and ideas, accepting they're different, the way they'll apply the skills are different, the way they process information, and they're kind of teaching each other. I feel like I'm really doing my job when I'm standing back and the class are all professionally discussing, well, I would do this because, and they say, well, no, I would do it this way because. So for me, that's a real pleasure within the classroom, and it is part of the facilitated discussion is to enable them to do that. That's why we have quite a bit of time on the face-to-face days. So,
well, it is actually a recognised method of learning is peer learning, you know, and having those discussions. And you know, people have always asked me for years what my job title is, and you know, I use the word that you used in our sort of pre-chat was I'm a facilitator. I just, you know, facilitate discussion and learning, whether that's be to a one-to-one client. And I'm actually going back into clinical practice this week. I've got 4 clients, which is the first time in ages, just because of circumstances. People have rang me up out of the blue. So I've got my clinic to set up again, and I'm working tomorrow in clinic. So I will be facilitating, you know, their education, their understanding of their condition, their understanding of how they might make themselves better, what they might be doing to antagonize the situation. So I think that's what we are as therapists. We are facilitators. Has anybody else got any questions while we are here? Scott, anything that come in from members?
Not from members. I think everything's been covered so far. I've got a couple of little things here. So the assessment side of it and kind of the ongoing side of it. So what kind of, is there any equipment, anything like that how is that kind of side of it measured and
basically
assessed?
it's what's the process?
Yeah. So the process that you learn when you're becoming a biomechanics coach. Yeah.
Yeah.
Okay.
So like when you so I come on your course and I leave. What kind of things do I need afterwards?
Just what you have as a sports therapist, exactly the same. So you don't need a video camera. You don't need you just need a massage table, maybe a step. So we do some drop testing for ligament dominance, a cross on the floor for leg dominance, which if you've got athletes, that's quite helpful tests to use. But other than that, it's the same. So you don't need any other equipment. So this is again what Martin found in his research. He had all this expensive equipment, which is why everybody's coming to him. And he thought, well, surely there's an easier way. If you're pitch side, if you're on your own in a clinic, if you're a self-employed practitioner, you can't afford all of this expensive equipment. So it was quite a deliberate process to make it as simplistic as possible, that you don't need anything. The tests are, and I guess I always talk about the flaws to the system. I'm quite open about this, flaws to every system when it relates to the body, because we're all so different. We're trying to fit bodies into a system to follow. But the idea is that you can do a benchmark, apply an intervention, and then redo the benchmark and see improvements, the same as you would do when you learn in sports therapy. But this process of ruling things out and being able to reevaluate the whole client, and when you start to see foot function improve, when you've done a pelvic MET, or you know, that's the side of it. I think that is different in terms of the application in clinical practice, where it's all about the symptoms. And what I'm really aware of is your audience are basically working with people who are symptomatic, and the program is not about symptoms. It's about improving function and movement. And if the symptoms improve as a side effect, great. But the whole point of the system is to improve the function of the entire body rather than simply reduce the symptoms. And I think that's what you were touching on earlier, Gary, when you talked about Daley Thompson. He ended up with an injury, but he might not have got it had he been fully evaluated, you know, fully through the program. And another example is Derek Redmond, 92 Barcelona Olympics. He was another client of Martin's, and he was actually sprinting again 10 days later after going through the process. So it isn't just about symptoms. In fact, it's quite the opposite. It's about function and movement to reduce risk and optimize performance, but in the simplest way possible. So you can literally do it at the side of the track. You could do it, you know, in a therapy room, but you don't need any equipment, basically.
Could I ask then, if this screening process is there a correlation between the results, the objective data you may have in identifying potential for injury? And if that's the case, can we then adjust the training protocol to prevent that injury? You mentioned Daley Thompson again, to prevent Daley Thompson being injured. On, you know, what was really silly, it was just falling onto the mat that caused it.
Yeah, and you talk about, we hear clients come in and say, I just bent over and picked a feather up, my back went. There's a chance it was waiting to happen. So it's predominantly about prevention, but it's very difficult to prove you're preventing something unless you're assessing everything. And so Martin's work was in correlation to their medical history. And Daley Thompson, as I say, was part of that. So while he's measuring on the isokinetics and the clinical manual tests, comparing those, following their medical history, he could see a pattern that while they would get symptomatic, for example, in the shoulder, it was often when he remedied what was happening in the pelvis on the opposite side, that the shoulder got better long term. And if he was a clinician, a therapist, he would treat the shoulder. If he's a PT, he does an exercise for the hip. So this is where you have these different skill sets on the same client for the same goal, but working together for the better, for the greater good for the whole client and the business between the two professionals.
How do you rule out then, just being devil's advocate here, you mentioned that you do an objective test, you apply an intervention, an MET or a soft tissue intervention, and then you retest. There is a body of evidence that suggests that familiarity with a test will show an improvement. How can we, if you like, satisfy ourselves that our intervention is what's, you know, making the improvement?
Yeah, well, that's repeating the process and over time finding that when they come in cold, if you like, the assessment stays negative. So there's no perfect solution. We don't know. It could all be a placebo. You know, I know the conversations we have in the STA groups, and I love that critical analysis. I love the challenge. I'm a little bit gutted. I haven't got some really hard questions coming in and people chucking things at me, but I think it's the same with any process, Gary, that there's no perfect solution. But if you have a system that you follow, and over time the assessments get better, over time they feel better, over time symptoms reduce, you know, that's the point. And if you strip back everything we're all doing, we're all trying to take a client to the same point. They all want to be confident, and that's what they're buying from us, is confidence in three things: how they look, feel and move, or any combination of those three things. And it doesn't matter whether you do massage, maybe massage works, maybe an exercise works as well, maybe only one works. But this is about filling a gap or adding skills or ideas or tools so that the therapists have got something else to go to. And if you're testing continuously and initially everything's positive, or they've got a sore back, and the knees are unstable, the mid-tarsal joints a bit loose, pec minors overactive, median nerves tight within a certain range of motion. And then as you start to give them exercises and reassess them repeatedly over time, and the tests are coming back consistently negative, if you chucked everything at them, you don't know what's worked. So a part of the system is to kind of hold back a little bit, and almost rule each body part out one by one and see what happens to the rest of the body. So we start with the pelvis basically, and this is where it kind of butts up against sports therapy, because if they've come with a sore shoulder, they want the shoulder rubbed, in simple terms. So if you're just giving them a pelvic exercise, that doesn't work. So you've got this tandem challenge of, was it the treatment I did on the shoulder, or was it the exercise I did on the pelvis on the opposite side? We don't know. It's just time that will tell whatever term effect.
I think some of the work that we've been trying to do over the past decade is to teach or show our therapists that, you know, we haven't got magic hands. What we have got is the luxury of spending time with our clients. And the deeper you go into somebody's history, the more likely you are to find that yes, they've got a shoulder problem, but they've also had discomfort when walking or sitting or getting from sitting to standing. So the deeper we dive into their history, and that doesn't have to be done in a sort of formal consultation process, that can take place. You know, we're touching people nicely, we're administering some exercises, but at the same time we're inspiring them, motivating them, in your words, giving them confidence to move, you know, letting them know that it's actually quite safe in a clinical environment to move, and to move within that sort of painful arc a little bit. So I really like the idea that we're giving confidence. We're treating people nicely, we're speaking to them nicely, we're facilitating change for them. And one of the things that I remember, I came over to Mike's place in Harborne, and we did the pelvic tests. Was Mike said something along the lines of, you know, when you get up in the morning, what I want you to do is investigate how your pelvis works, how it moves. And I do it with a lot of shoulder clients. He said, get up in the morning, you know, investigate how your shoulder moves. You know, have you got flexion? Have you got abduction? Have you got external rotation, medial rotation? And just see how things move. So giving them the confidence to investigate movement and not be worried and catastrophized by the thought of pain, I think is really important as a therapist.
And I think that's where this works so nicely, Gary, for therapists. Is I think one thing that can be a challenge is when the client gives ownership to the therapist of their pain. And so what you're talking about is reversing that in the nicest possible way and empowering the client to take ownership of their body and then therefore their symptoms. And we are an analyst, a guide with some suggestions on explore your movement in the morning, for example. And my first session is always 2 hours, and there's only 20 minutes of that I'm doing physical assessment. The rest is airtime. The rest is about developing rapport, really learning about the client afterwards, talking about their lifestyle. So that really the assessment is just that tiny part. And I know a lot of the conversations in the STA group are about the whole person. Pain is not, you know, we've got to put everything into the mix. You can't have that will solve that pain, give that a friction on infra and it will solve it. You know, we know, I think we know that now. And so we don't know what that one thing definitely is that actually made the symptoms go away. Maybe it was just their psychology, their attitude towards their movement, and actually the fact they got more confident to move and their symptoms dissipated. So it's quite a difficult role, I think, for sports therapists when it is about symptoms that are quite subjective very often.
To finish up with, then, could you describe one of the screens that you do so that our audience has a broader understanding of what they're assessing and why?
Yeah, so if a client came in and I was doing a standard assessment, I would explain to them at the very beginning, some of the tests you'd be lying down on the table, some we'd be sitting, some standing, and if you're able, some will be small hopping moves. I'll be touching you, I might draw on your ankle bones, move you around and see your back if you don't mind taking your top off. And then the assessment process would take place. I do it in the clinic here. They would lie down and we would assess various movements in the pelvis. So we use tests like Downing sign, Forsign, which is in the clinical world known as Patrick Faber's. But again, we use it as range and symmetry. But we're taking into account function and movement over alignment. So getting more aligned is great, but we don't expect perfect symmetry. We would assess then the spine, each plane of motion, ranges of motion, whether they have any symptoms when they're doing it. I will ask permission to film, because I think filming a before and after their improvement is very powerful to the client to actually see something change. We look at the feet. There are 6 tests for foot function to identify if they have a propensity for pronation, knee stability, hopping tests, and the shoulder screens. And it would take around about, for me, it's about 20 minutes now. There's about 27 screens. But there are other screens, there's about 43 in total, that would come in at later dates when they're ready for it. So we use the analogy of the pyramid. So the basic screen is that, some lying, some standing, some sitting. They'll be moving their arms in certain directions. And it's to isolate as much as you can certain actions to identify the protractors or overactive, whatever language you want to use. We want them to open up a little bit more maybe at some point. Did that answer your question? I'm not so sure.
Yeah, sure. Just to make sure, Helen, Claire, as guests here on the podcast, have you got anything? Do you need more clarity on anything, or are you satisfied? Can't hear you, Helen.
No, that's fine, thank you.
Okay, Claire, anything from you? Claire might be just listening while she's coming on.
Nodding off,
Yeah, all good.
All good. All right, Scott, anything from you?
Just one last one, which I don't want to make it drag on. So it kind of goes on from their assessment kind of side of it. So how do you take the baseline measures? How do you kind of take that? How do you get the repeatability? So when you're doing the assessments, is the measurements that need to be taken? So I know when they come in next time, it's going to be reliable. How is that kind of side of it come into it?
Yeah, so we did a lot of work, and we actually took apart some of the tests from clinical practice to make them as objective as we can get. So very specific placement of bony landmarks, if you're crossing the ankle over and above the knee, for example, so that when we teach it to practitioners coming in, we're very specific about the ASIs need to be the same height, the lateral malleolus needs to be across the outside of the thigh above the patella, you're measuring off the lateral condyle of the knee, so that we have these very specific benchmarks. There's some degree of subjectivity and repeatability, human error, etc. I get all of that, and I agree. But it's as standard as you can get in terms of even with Thomas test, for example, and that became modified for leveling off the pelvis. There are several different ways that we've seen some tests done, but we sort of as a group, Mike Rice, Martin Fletch, and the others, we would challenge even the evidence-based model as we read it and say, well, that actually still leaves room for subjectivity. Could we not do it like this because of the anatomy here? So we try to be as objective as you can, Scott, but I mean, it's always going to be a challenge. And we communicate this in the course as the way they write things down, in terms of if there's a 2 mil leg difference, that's subjective and depends on where you put your markers. We agree with that. But again, as you repeat it over time, A, they get more practice, and B, if they're improving how they move and they feel better, we're going in the right direction. This isn't about precision. It's just not, I don't think that's possible without, even machinery isn't always that precise. It depends on the placement of the camera or the markers. So it's what we've got that for us satisfied us as much as it could do at this point.
And that again enforces what you said earlier about not having to have expensive machinery. And for anybody who listened to our podcast last night, it was investigating the use of artificial intelligence by using movement screens that were which were judged and objective data was artificially gained. And a lot of the questions there were, how reliable is this? So you're always going to get some reliability issues, irrespective of what you do, product placement, measuring equipment placement, etc. So yeah, that answers my question. Scott, does that answer your question there?
Yeah.
Alex, hi.
Good evening.
Just finished work.
I have, yeah.
Yeah, been listening in. Have you got any questions for Rachel? We're just about to tie it up with the recording, then we're going to carry on with our normal coffee evening chat.
No, I haven't really. I probably haven't. Probably ones I had have probably just been, yeah, they've probably come up already. So I'll watch the recording. And
okay then. Rachel, anything finally from yourself?
No, just thank you very much for having me on. And if any questions come after this, then they can email me, rachel@biomechanicseducation.com, or through the group, or send them through.
Yeah, Rachel does have access to our members groups. If anybody wants to follow up on this, just put something in the group and she will read that. Thank you very much for your time this evening, Rachel. No doubt we'll be in touch again soon, and look forward to seeing if you're going to Therapy Expo this year.
Thank you.
All right. Thanks very much. Scott, do you want to stop the recording then, and we'll go on with